6-year-old boy, 6-year-old boy, Tom, has come with history of exercise intolerance. Past history is that he was operated in early years for a cardiac condition. Now he's come with exercise intolerance. You have to do the cardiovascular examination. Okay.
Okay.
So here's start. Do you have any doll or anything, or you want to do it verbally?
Actually, I have a baby doll. I don't have a big doll.
It doesn't matter. Do it on the baby doll. I'll give you the findings as we go along. Open your camera then. Let me. Okay, that's good. Now
Am I
let's.
audible?
Yes, yes, we can see you and the doll well. Okay, go ahead.
Yeah. Hello.
Hello.
Hello, Tom. Is your mom with you?
So
Hello.
first look at Tom and ask me what does he look like and all that. I'll give you the findings.
I'm asking, is there a mom? Tom's mom is there, ma'am?
Yeah, he's with his mother.
Yeah. Hello, ma'am. I'm Dr. Soumya, one of the child doctors here. I would like to examine Tom today. Is that okay with you?
Yes, go ahead.
Yeah. I'm washing my hands. And hello, Tom. How are you?
So he says, I'm fine.
Okay. Oh, you have very nice shirt. And I'm looking at his hands. I'm looking for some paler clubbing.
He has mild clubbing, residual clubbing.
Cyanosis.
No cyanosis.
Okay. And I'm checking for his radial pulse. What is the pulse rate? The volume?
Yeah, radial pulse is around 90 per minute. Volume is normal.
I'm looking for any dysmorphic, any history of dysmorphic features.
No, he appears to be looking like his mother, normal.
Okay. I'm looking in his eyes for pallor and any
So how will you check
interest.
the pallor?
I'm looking in his palpebral conjunctiva.
Okay. He's not pale.
Okay, Tom, can you look down for me? I'm looking
Yes,
for
he looks
icterus.
down. Okay. No, he's not ecteric.
Okay, I'm looking into his oral cavity. Tom, can you open your mouth for me, please?
Yes, he opens the mouth.
I'm checking his oral cavity for pallor, any cyanosis, or any dental hygiene of Tom.
Okay, he's got dental caries. And what about how will you check the cyanosis?
In the tongue, blue color,
Hmm?
bluish discoloration, bluish
Tell him to touch the
discoloration.
tongue with the roof of the mouth. Show it, demonstrate it to him. Touch your tongue like this, like that.
Okay.
So he doesn't have central cyanosis and there's no pallor. I mean, normally we don't check for pallor in the mouth, only in the eyes. Dental hygiene, cyanosis, and high arch palate. So there's no high arch palate. Next.
And I'm looking for lymph nodes. I'm going back of the Tom. I'm checking for any palpable lymph nodes, cervical and postauricular and supraclavicular.
This is not required. Why do you want to check lymph nodes and cardiovascular? Even in the abdomen should be bright at the end. Don't do this. In the neck, what will you see? Just do an inspection, see any prominent veins or not. He's less than 8 years, so you can't even do the, JVP, and you will mention it at the end if he's like above 8 years or 8 years. All right, so just see for any prominent veins, any scar marks in the neck, and don't touch the neck or anything. Okay, go straight to the chest. You have a lot of things to do in the chest.
Okay, Tom. Can I please open your shirt and can I expose his
Yeah.
chest?
Yes, so his mother's exposed the chest for you.
Okay, thank you.
Okay, I'll
I'm
show you
looking.
the yeah. So I'll show you the chest. 1 minute. The picture. This is the chest. Can you see it?
Yeah. Tom, can you lie down for me?
Yes, he's lying down.
Yeah, I'm looking at his neck for any visible scars and any visible pulsations over there.
Yes.
I can on inspection I can see midline sternotomy scar, um, and two small maybe probably drain scars. And I would
Mhm.
like to look in his both axilla and also the back for any scars over there.
Okay, so he has one more.
Okay, right lateral thoracic. I can see right lateral thoracotomy scar and any scars over the back.
No, no other scars.
Okay. I Can I see any visible pulsations over the chest?
No, there's no visible pulsations either.
I am looking for the visible apex impulse. Where can I see it? Is it visible?
No, it's not.
Okay. Um, I'm rubbing my hands to get it warm. I'm putting both my palms on the chest to feel for the apical impulse.
Okay, so how will you locate the apex first?
I'm putting both
Suppose
my
you
hands
find it
like,
on the fifth intercostal space lateral to the mid-clavicular line. Then
yeah,
how would you confirm it? I mean, the position, I mean.
yeah. I'm putting my palm um,
Yeah,
on
so you
the
count the apex speed impulse. Now you need to count the intercostal spaces. How will you do that?
from the sternal angle. I'll count the
Yeah.
intercostal spaces.
Yes, exactly. Okay.
Mm,
With the fifth intercostal space, medial to the mid-clavicular line, not lateral, medial.
Okay. I am feeling for other any other palpable impulses on the chest
No.
in la- lateral sternal borders, upper and
Okay.
any
Okay.
thrills palpable.
Sorry.
I'm looking for any thrills over
Okay.
lower left.
Which areas will check for the thrills? One lower left sternal border. Tell me all of them together.
I'm looking at the apex and lower left sternal border and upper second intercostal spaces on right and left side.
And
For any
suprasternal notch and neck as well. Okay. 6 areas.
yes.
All right. So no, there is a thrill on the upper left sternal edge in the second intercostal space.
Okay.
No other
Uh,
place.
okay. I'm looking for the parasternal heave. Is it present?
No, there's no parasternal heave.
Okay. Um, I would like to check for the cardiac borders by percussion. Is that okay with?
No,
I'm
don't do
asking.
percussion in this exam. There's no percussion.
Okay, I'm trying to auscultate the apex.
Okay.
Um,
So what do you want to see in the apex?
I'm looking for the murmur. Is
Okay.
uh,
Ask for the heart
it
sounds and then
backward?
the added sounds. So no added
Yes.
sound here. Only normal S1, S2.
Okay, I'm looking at the lower left sternal border for heart sounds, murmur.
No murmur.
I'm looking at upper right
There's an
second
ejection
interval.
systolic murmur on the left side, not on the right, but left side.
Okay. It's of grade.
You have to make your own grade, right? So what do you think? If there is a thrill present, what would be the grade?
It could be a grade 3,
Are you sure?
grade 3 or 4.
4 is a thrill positive and it could be 4 or 5. If there's no thrill, 2 or 3. Okay.
Okay. We say S2 sound. It's a split or
I
a
gave you
single
a
S2
thrill,
long.
right? If there's a thrill, it has to be 4 or 4 plus. It can't be 6. 6 is too loud. So if you have a thrill, it is 4 or 5. That's it. And you can't have one grade murmur either. You'll have 2 or 3 if there is no thrill. Just remember that. You have to decide this on your own. The examiners are going to tell you. So go ahead. What's next?
Yeah, I'm looking for the S2. Is it split? Is it loud?
No, it's not.
Upper right sternal.
Not split, not loud.
Okay. Uh, I would uh, I would look For the radiation of the murmur, is it radiating to the back?
Yes, it is.
Is it radiating to the neck?
No.
And I would like to palpate for the organomegaly in the liver
Okay,
and the
before that, you need to do the dynamic auscultation. Dynamic auscultation is position changing or an expiration or inspiration. So any of those maneuvers you want to do it for this child?
yeah. Tom, can you take deep breath for me? Is it, and please hold it. Is
Yeah,
it,
so what do you think? If it's on the left upper sternal edge, it will increase on inspiration or on expiration?
it will increase in inspiration, left
Yes.
side.
Okay, so it's increasing on inspiration. Then abdomen, you have to take permission from the examiner and also from the child saying, do you have any pain anywhere? So I'd like to check for the, what do you want to check in the abdomen?
I would like to check for the congestive, any congestive hepatomegaly or splenomegaly.
Okay, so then ask the child, do you have any tummy pain? Then start. So he doesn't have any hepatosplenomegaly. Next.
Okay, I would like to complete my examination by auscultating for the lung fields for any basal
Do
cracks.
that when you're doing the back, okay? Don't go back and forth already, okay? When you are doing the radiation of the murmur, check the lung bases, sacral edema as well, completed
And
scar marks and everything. And then
I,
go to the abdomen, okay? Abdomen is not per se part of the cardiovascular examination, so you need to leave it later. And then anything else in the lower limbs?
I would like to check for all limb all four limb blood pressure
Okay,
later, and I would like to feel for the femorals and the dorsalis pecs also.
okay,
Both lower.
peripheral pulses and forelimb blood pressure, anything else?
Yeah, that's
Okay, so present your case.
uh, today I have examined 6-year-old Tom uh, who presented who has midline sternotomy scar and right lateral thoracotomy scar previously, and now he presented with exercise intolerance, and I can um, I can feel palpable thrill in the upper right sternal border, and on my examination,
Just
any
give me the
different
positive findings. The examiner is going to be very impatient, okay? Just give me the positive findings and your interpretation. What is the positive finding?
an ejection systolic murmur of grade 4/6 in upper right sternal border. Um, and based on my examination, which is radiating to the back, which is on finally can be a case of complex congenital cyanotic heart disease with a residual pulmonary stenotic form.
Okay, so what is the differentials you may have for the complex congenital heart disease? Any differentials?
It can be a tetralogy of Fallot.
Okay, so what expectation do you have from this child? What complications he's having that he's having exercise intolerance if it's an TOF, operated TOF?
Yeah, it's operated of, but pulmonary stenosis, it can lead to right ventricular hypertrophy and right ventricular failure, which may lead to this
Okay,
exercise
what
intolerance.
else? What else?
And he also has dental caries and
Okay, no, I'm asking about exercise intolerance. Yes, dental caries would be the important thing you needed to mention when we were presenting the case. What else? Any other differentials for exercise intolerance in this child operated case of TOF?
any infections, superadded infections, which can lead to any presence of
Okay,
fever.
all right. So how would you like to investigate this child?
Sorry.
Investigations.
Yeah, I would like to do a full blood count. I would like to take a detailed history from the mother, and later I would like to investigate by doing a full blood count to rule out any presence of the infections and to check for the anemia, which might lead to this intolerance. And I would like to do an uh,
What
ESR
else?
and CRP to rule out any presence of infection, and like to check
He
for
doesn't have
the
infection. He doesn't have any history of any
chest X-ray.
infection. What else will you do?
I would like to take a chest X-ray and to look for any presence of cardiomegaly, and I would like to take an electrocardiogram, uh, which may rule
What
out
will
the
you see in
presence
the
of
electrocardiogram?
I will look for the right ventricular hypertrophy changes with peak R waves or RSR patterns in V1,
Okay.
and I would like to do a two-dimensional echocardiography.
And what will you try to rule out in that echo?
I would like to check for the stenosis, extent of the stenosis, and any presence of regurgitations. And
Okay, and the time is actually quite over. You have to speed up your presentation thing. So what advice you'd like to give the mother?
uh, I will arrange a meeting with a cardiologist, and
What are the advices we give in any post-op cases?
I
And
would
especially with exercise
for 6
intolerance.
months after the surgery, the child will require prophylaxis treatment for 6 months, and the child has to avoid any strenuous activities and contact sports like boxing and rugby. And the child should not go to high altitude regions or places.
Okay, what
Uh,
else?
they have to maintain proper dental hygiene to
Yes,
avoid
his
any.
dental varies, so we should say that. What else? Avoiding anything else other than altitudes.
Avoiding contact sports and strenuous activities.
Actually, it's not contact sports. Contact sports is for a brittle bone disease or the child has a bleeding disorder. It's only strenuous activities in cardiac conditions. Okay, and avoiding of tattooing and piercing because we want to prevent the infective endocarditis. So dental hygiene and these two precautions are for the infective endocarditis. We don't need to say about the 6 months. He was operated long time back. We don't need to say he needs prophylaxis up till 6 months post-op. But yeah, he might need another surgery if he develop the complications of residual infundibular stenosis, pulmonary regurg, or he might also develop arrhythmias post-op. That's why the ECG is being done, other than seeing for the right ventricular hypertrophy and all that. But you needed to do the echo to see for pulmonary regurg and any residual pulmonary stenosis. Now the child is growing, so his body is not able to handle it, and now is having syncope. So the child, they come either with syncope, aortic stenosis, or exercise intolerance. In the case of a operated case of TOF, this is a very repeated case. It's come a lot in the previous years, both in the virtual exam and with the patient. So you need to know the post-op TOF complications thoroughly, okay? And you needed to say other than the forelimb BP, you have to say, I like to plot his dimensions on the anthropometric measurements according to his age and sex, okay? Without which this MRCPCH will not be complete. You have to talk about the centile charts without that on every clinical station. And then in the cardiac station, as I said, if he is having, cyanosis, you mentioned the oxygen saturation is 8 and above, JVP, forelimb blood pressure, whatever you could not do. For example, if you didn't have the time to do the abdominal examination, you'll mention that. don't forget the anthropometric measurements because they may not give you charts in the beginning. So you need to mention, I'd like to plot him because he has a heart disease. So he might be on faltering growth sometimes. Okay, and don't mention so many investigations, CBC, ESR, CRP, and explain so much in detail. You can say CBC, ESR, CRP to rule out infections and anemia, make it shorter, okay? And then say the integral parts. The child may have arrhythmias, remember? So we won't just do an ECG, we'll do a Holter monitoring, okay? 24-hour ECG monitoring. And if needed, we might do cardiac catheterization. Will involve obviously the cardiologist for the echo and everything. So you need to say the three advices. In additional, we will say about the strenuous exercise because he has, exercise intolerance. So what are the indications of infective endocarditis prophylaxis? Other than this, in a kid who's operated 6 months post-op, what other indications might there be?
When there is a prosthetic valve.
No, I'm not asking you, I'm asking her. Let her complete. Yeah, go ahead.
Yeah, presence of any prosthetic
Right. One is a prosthetic valve. What else?
post-op 6 months.
Yeah, post-op 6 months. Okay. What else?
History of infective endocarditis.
Yeah, previous history. What else?
History. Yes, perfect.
Okay, now Bella, you can take over. What are the indications?
Other than these which was mentioned, if
Yeah, she
there is
mentioned.
a cyanotic congenital heart disease, if there is
Which
a
one?
residual defect of
Unoperated cyanotic.
unoperable cyanotic heart, and if there is a residual defect, residual
Yeah,
regurg.
indicators or the child has an obstructive lesion or acquired heart disease like rheumatic heart disease. Okay, so this would be important. Residual, post-op they might have leakages like aortic regurg and all that, and obstructive lesions like unoperated, HOCM or aortic stenosis. This also will be an indication for there are high risk cases for infective endocarditis, so you need to give them prophylaxis. So this child is basically not coming into the thing unless he has a previous history, okay, or he's a post-op case in the past 6 months, or if the child had a prosthetic valve. You should also know that prosthetic valves come in the exam, and you should recognize the metallic click. Okay, this is very important. People miss the metallic click a lot. Okay, and you will get these metallic clicks. So you better go to the cardiac ward and hear as much as murmurs as possible. Okay. And yes, you must rule out dextrocardia. So this child didn't have it, but they're giving a lot of dextrocardia nowadays. There was one case that came in the cardiac station, and in the same exam, it came another dextrocardia in the respi. So you can get multiple cases even. So we better check for rule out dextrocardia in both cardiac and respiratory stations. Okay. Oh yeah, in the beginning you did check for the clubbing and cyanosis, but you needed to check for the grade of the clubbing. Then you needed to check for the signs of infective endocarditis. You did not do the full pulse examination. You only asked for the volume, rate, and I think that's all you asked about. Radial delay, you didn't ask for radiofemoral delay and water hammer pulse. You need to do the whole examination of the pulse. And then obviously you will go towards say that I'll do the blood pressure in the end and go towards the eyes and ask the child to pull down his lids, check for the pallor, check for the icterus, mouth that we already discussed the three things, dental hygiene, central cyanosis and Howard's palate. Neck, before you do the neck examination, put him in 45 degrees, okay? Make him sit in a 45 degrees, then check for the prominent veins and any scars. etc. Then expose the chest and start with the a proper inspection of the chest, side and back, everything you check. You need to rule out scar marks. If you miss anything, it will be another problem. I mean, you might miss the diagnosis if you miss a scar mark. If the child had a lateral thoracotomy scar mark, so you should auscultate the scar mark because you might have a shunt mark. So try to do auscultate shunts as well. This child is a post. He might not have a if he's a corrected one without any palliative surgery, he might just have a median sternotomy scar mark. I gave you a lateral thoracotomy so you don't miss it, just to remind you. Otherwise, it might just be a median sternotomy without any lateral thoracotomy. They're not doing. They're going just direct for the corrective procedure nowadays. All right, so then yes, you have to check the palpation for the apex bead, rule out dextrocardia, the character of the apex bead, okay, and then they palpate for the parasternal heave and the thrills. The thrills have to be checked in the neck and the suprasternal notch as well, don't forget. And then you see auscultate the heart sounds, any added sounds, and where it is radiating to, depending on the, if it's upper left sternal edge, as I told you, you have to check the neck and the back as you did, and also do the dynamic auscultation, meaning inspiration and expiration. This would confirm this is a right heart lesion. So then rule out any hepatomegaly and rule out all signs of heart failure, meaning basal creps and all that. When you're doing the back auscultation, complete the back. Don't make him sit up and lie down, sit up and lie down. Complete everything at the back. When you're checking for the radiation, check also for the basal creps. Ask him to take a deep breath. Take permission to expose the sacral area, and then check for the sacral edema, and then you can do the lower limb, and then take permission for the abdomen. Okay, so try to be fast. Okay, I can clearly see your smoothness has not come. You still have a lot of time, so just not only in the examination you have to be smooth, but also in the presentation. Both these things are important. Okay.
Yes. I have a doubt.